it's a real indeed pleasure to invite you all to our TRICS IDCCM free webinar batch 2. Why it is batch 2? Because we have started in the first session 6 months back, and we are really fortunate to have all our candidates passed in the TRICS IDCCM course, as well as I would say in the theory as well as practical. So it's a 100% clean sweep. The theory was 90% and the practical was 100%. So somebody would be surprised why the theory was 90%, because two candidates didn't appear the exam. So that was the reason. And we have a group of very dynamic young intensivists as well as teachers. They were our students. Now they are the teachers and we are the students. So we are fortunate to have Dr. Alisha Chaudhary, who is the consultant intensivist at Utkal Hospital, at some alternate hospital, sorry. And anyway, it's all like interchangeable.
Same in Bhubaneswar.
It's election time, so you know. So, and we have also with me Dr. Sasi and my co-director of this program, Dr. Sanant Kumar Das from Australia, and two of our successful candidates. I would not say candidates, they are now the teachers in the same league as we are in the TRICS IDCCM. So Dr. Vibhuti Padjoshi and Dr. Nimrit. So they are the successful candidates and they would be sharing some of the tips and strategies that they have exercised in the last exam preparatory course as well as also during their exam preparation. So without further delay, I would request the lead faculty, Dr. Alisa, to take over the whole proceedings.
So, very good evening to all. So, as Tapas sir said that it has been quite hectic and very dynamic last 6 months with lot of work. We started with TRICS IDCCM batch 1. With December to almost February, we were involved in the theory. So there were a lot of core faculties because that was we were building the foundation of the program with all the collection of study materials, articles, and papers, making modules and debrief videos. And then with that, we had around 50 candidates, out of which around I think 35 to 37 had appeared. And then we continued the journey with them to TRICS IDCCM practicals also, which was after the results of around 1.5 months. And very happy to say also that in our practicals, we had all the students who had appeared had cleared with like flying colors, 100% results. And it makes me feel very proud, I can say, on behalf of all my faculties to see our students have done so well. Uh, Obviously, it was all their effort. I do not deny that, but I can take a little pride in saying that we have also helped them in that, and I think they can tell you better about that. So we'll start with a free webinar. So exams are coming soon. Now is the time to start studying. Best of luck. You all are going to need it, right? And all your exams are on September 12th. If you're aware, is the IDCCM theory exam. So, what would be the agenda of this talk? The welcome address, as we said, gratitude notes from students, know your faculties, what is the course content and schedule, feedback from previous students, and finally, sample exam questions for practice. No point in having a webinar and just keeping on, talking good about the course or mentioning our schedule or how we are doing it and just listen very good feedbacks. We thought if we could practice some sample questions with you, at least even 5 questions, so that your mind start running. You get into the exam league. You start thinking like you are going to give exams in next 2 to 3 months. That will be really helpful for you. And that's what we believe also in our course, that exam preparation should always be a teamwork and we should all do it together so that you also enjoy the preparation and read really well. So gratitude notes from students as who all had cleared these we had got through our WhatsApp. Many of them I just wanted to share with you. It was very kind of them to send these messages to us in our WhatsApp group. So, and appreciating our efforts. And I can tell, these are our core team faculties right now. That's me at the first, and Dr. Sashi. She is at presently in Vijaya Hospitals, Chennai. This is Dr. Hariharan. He is in Royal Hospital, Coimbatore. Dr. Ankit from Nepal. Dr. Arun. He is in Dr. Arun is in JP Hospitals, Rourkela. Dr. Pawan Tilak is in Royal Hospital, Coimbatore. And Dr. Aditi, who's in KMC Hospitals, Mangalore. And our course directors are Dr. Tapas Kumar Sahu, sir. He's Director, Department of Critical Care Medicine, Vedanta Hospital, Ranchi. And Dr. Sanant Das, he's the consultant intensivist and teacher in Townsville Hospital, Australia. So these are our core team of faculties and our course directors. And all I can tell you that all of us along the whole team has put really a lot of hard work to get this program into functioning in this mode and in a structured pattern so that not any day you feel in your preparation time of 2.5 to 3 months that we have not kept you on your toes and not made you read. Now, what is the exam pattern when I talk about IDCCM? As all of you know, you're going to write it in on September 12th. So it is a MCQ based paper where there will be a single best answer. There will be a question with 4 options. You'll have to choose the single best answer. The best thing about this exam, I always like this, if there is no negative marking in this exam. There are total 100 questions in 3 hours, and the passing cutoff varies depending on the highest mark of the candidate has secured. Based on that, it's basically like a percentile system. Okay. And what kind of materials you are expected to read? Standard textbooks, so it can vary. Like people say, I read Washington, somebody says I read Oz, somebody tells I read Pink or Irvin Rippe. But you have to understand whether you read any of these books, that's not the end of it. You have to read in and around the topics because critical care is such a vast subject. You cannot limit yourself in preparation to one book. Most importantly, your concepts have to be clear because the questions are not going to be always just fact based questions just taken off directly from the book. It will be sometimes, suppose, for example, if it is related to something like spinal injuries. So it's not necessary that they're going to ask you this much percentage of spinal injuries go into spinal shock, or these patients develop bradycardia. Sometimes it can be just concept based questions. This patient has come with a spinal injury, traumatic spinal injury to your ICU. So what are the orders you are going to give? Look for a blood map, maintaining the map, what is the position. So concepts are also important. Sometimes you need to even refer to medicine or other specialty books and frequent discussion among colleagues. So apart from what I always suggest is apart from books, you need to read certain articles and guidelines so that your concepts regarding one particular topic is quite strong, and that is going to help you answer the exam. Okay, MCQ books are good, I agree, you need them for practice because you need to time yourselves, but reading only MCQ books and writing the exam is not going to help because you're not going to get the same question from the MCQ book. Rather, if your concepts are clear and your theory preparation is good, then this is going to help you more to appear for the exam better. So apart from that, so there's a lot of unfinished syllabus because, as I said, the syllabus is like really vast. So how can we help you? We feel that it is always a teamwork, and together everyone can achieve more. There comes our course. Now, if you look at this, what is the thing we are trying to offer you in this course? So if you look at this, you look at the date. So we start the course from 8th of June. There's a basic introductory class to just tell you again about the course. And so suppose, like, look at this. 15th is a Saturday, right? So how have we planned? We have divided all these into 10 modules. Okay, your whole IDCCM course, we have put it as 10 modules. So on June 8th night, okay, you are going to receive in a Google Drive all the articles which all of us as faculties have handpicked and selected for you to help you like as a reading material or like what you tell an article bank kind of thing. Okay, so all these articles you are going to receive on 8th night. On 15th, that is a Saturday, from 15th morning till 16th evening, 15th morning 8 a.m. to 16th evening 5 p.m., you'll receive a Google link for your toxicology module exam. Okay, so it will be an MCQ based exam. There'll be around 30 to 40 questions. Now the link is open for 1.5 days because we understand being in ICU how difficult it is to write exams when you have shift duties. You don't know what time you are going to come back. So we have kept the exam link open for almost 1.5 days. Then on the 16th evening, you are going to get a debrief video which we have already pre-recorded for toxicology module to listen to the description answers of all the questions you have appeared in the toxicology mock exam module, along with explanations, along with some important pointers to help you for preparation for exam for that particular module. And on the same day night of 16th night, you are going to so on the same day 16th night, you are going to receive the articles for the next module, that is gastroenterology. Why we have kept it this pattern is, we know if we allow you to sit and just read for the exam, it is never going to happen. We didn't want to make your preparation boring. Theory is what you are going to read on your own. We are giving you handpicked articles so that you know what are the important points you should be ready with for the exams. We are giving you a mock exam for each module so that you also know that these questions, this is how the level of questions can be. And mind you, all the module questions have been prepared very tough. We want you to make all the mistakes possible right now. We want you to face all kind of tough questions right now so that later on the exam becomes an easy thing for you. It's a cakewalk for you. And every week, that is what, every week the module, if it is gastro or cardio or neuro, the prior week Sunday, you are going to get your materials. You will be reading along with your standard, whichever textbook you are following, these materials you are going to go through. And weekend, you will write the exam for that module. And by Sunday evening, you will get the debrief video of that particular module so that you can go to the debrief video at your leisure, listen to the answer. How can you approach, how the faculties have approached that one particular answer for that question, what all fundamentals they have used to crack that question. Also go through the important points they have mentioned to you, that these are the important things related to this topic which you should know for the exam. Now after you have finished all the 10 modules, so we start at almost 8th of June and it finishes by 18th of August. Look how extensive this is, because all of us, at least maximum of us in the faculties, majority of us are actually IDCCM, except for I think Dr. Hariharan, who's an FNB, and Dr. Ankit, who's DRNB. So he was an DM. So apart from, and Dr. Arun has an FNB, rest of all of us are IDCCM. So there's a mix of the faculties also to make sure you are exposed to all kinds of questions, and you're exposed to even all the knowledge so that you gain as much as possible from all the faculties. So all of us have faced this exam. That's why we hope we can guide you better. And at the end, on 26th of September, and so 26th of August and 2nd of September, we have kept two mock exams for you, which will be like your IDCCM theory exam, 3 hours, 100 questions. There also we are trying to, we are, going to give you at least 3 days to appear the exam at your own leisure, and you will be getting a debrief video of the mock exam questions also. And finally, on 12th September will be your D day, which will be your IDCCM main theory exam. So this is our course module, which we have structured it like this. It is time tested, and our students can actually speak better. So now our course is going to start on the 8th of June. So that is on the Saturday. So this is our course fees. You have an early bird offer which is valid till 5th of June. And you can contact Mr. Navneet from our technical team, who can guide you better regarding all details and technicalities. Now we shall proceed to the feedback from our previous students to know that how the course has helped them. And don't worry, these are already like unbiased, and it's nothing in our favor or anything. They are genuine feedbacks, which I think once you listen to them, you will have a better idea. Meanwhile, any doubts, any questions, kindly keep posting in the chat box. So I'll ask Dr. Nirmit if he's around. Can you unmute yourself and give us a feedback, or I mean guide these students, since you have recently cleared the exams. How did you do it, and how did you read, and how did you go about the exam?
Yes, ma'am. Good evening.
Before Dr. Nimrit starts, he was the most active member in the group, and always keeping everyone, all the faculties engaged with finding the correct answers as well as clarifying his doubts. One compliment for you, Dr. Nirmit. Yeah.
Also, one thing
Thank you for.
before proceeding, Dr. Nirmit. So this was all possible because we also had a dedicated WhatsApp group which was functioning 24/7. Because Dr. Nirmit is going to tell you how many doubts they had for each of us every day till the last day of the exam. I remember Dr. Nirmit calling me at night and asking, "What should I answer if this question comes?" And I had to tell him, "It's an exam tomorrow. Go and sleep. Don't bother now anymore." Yes, over to you, Dr. Nirmit.
Yes, ma'am. Good evening. So basically, my journey with tricks, I would start with it. I was obviously I was looking for some crash course, some like a crash course like thing to clear this exam. And most of the existing available modules are based on the video based lectures, and I was not keen on joining such course. And this was the best portion part of tricks, that you provide us the study material, and which we can read about at our own pace, and we can add on to the notes and whatever existing material we have. So that structure was the best thing that attracted me to join the course. And uh, and and next comes the structure, the way you prepared the modules were prepared for all the systems, and the way systems were organized, like few systems, few heavy systems, I mean long systems were there on few weeks, and then light systems were also there. So the structure was very easy to manage the schedule. So the structure of the tests and everything was quite well, and the MCQs also, they were so good. I would say that from the 100 questions that we appeared in the exam, approximately, at least I would say at least 10 questions I would have seen either in the mock tests or in the subject wise test which were conducted. So that is a very remarkable thing. At least so 10 to 15 percentage of your exam is cleared just by mere solving the module. So that is a very good thing of the exam, I mean your module.
Thank you, Nirmit. So I
and
have one more. Yeah, yeah. Please tell. He has more to
and
tell
apart,
us.
yes, and apart from that, yeah, all the faculties were available on, they were available so easily and so promptly that all our doubts, I don't think any of our doubts were left unanswered. So that was the best portion, that none of our doubts were left unanswered. And I know I had harassed a lot of you, but but it was good that you were so much receptive that I could ask you so easily. Yes, ma'am, I'm done with, ma'am, you
Oh,
can continue.
Thank you, Dr. Nirmit. And introducing Dr. Nirmit's identification, he was previously working in Lilavati Hospital doing the IDCSM, and after clearing the IDCSM, he's back to his hometown in Surat, and he's practicing his MD medicine, and now he is also IDCSM critical care.
next, one more candidate, Dr. Vibhuti Pattajoshi. He's also joined us. And I'll request him to unmute himself and just enlighten our candidates.
Good evening. Special thanks to Tapas sir, Sananta sir, and Alisa ma'am for giving me the platform to share my experience. And I would like to say that TRICS IDCCM is must go for every IDCCM student. It helps me immensely in preparing my IDCCM course. As we all know that ICU topics are vast, the syllabus is very vast, complicated, and very difficult for us to complete the A to Z of critical care in a 1 year time, along with the hectic ICU duties. So in that TRICS IDCCM module, the structure they have prepared, that immensely helped us. The modules, they have thoroughly they have covered each and every topic, and the important thing is that we have to cover every topic. Means the week we are getting for a particular system, we have to finish off that system and get ready for the exam. We must not keep any topic left pending for the next system which is getting to be started. And the second important thing is that they are coming up with very good questions and exam oriented questions, and the debrief videos of that question, they are covering almost everything. So we have to watch the debrief videos particularly. And the second part is the real time doubt clearing. Means WhatsApp, the online platform is there, we can clear our doubt anytime, they are available anytime to clear our doubts. And the best thing is that they all our faculties are IDCCM, and they have vast critical care experience, and they are guiding us and putting off in a place so that we can clear our IDCCM exams. And
Thank you, Vibhuti.
one thing I must say,
Yes, yes. Please complete.
one thing I must say, that the IDCCM, the standard of questions they have raising every year they have increasing the standard. So the TRICS IDCCM will help you particularly in and one more thing I must say that the TRICS IDCCM also helped me to clear my EDIC 1 exams. And thank you, and I must recommend everyone that TRICS IDCCM is a must go for IDCCM preparation.
So I'm happy to tell you that Dr. Vibhuti is actually my colleague in the same hospital. So he did his IDCCM with us, and he joined TRICS. And Dr. Subhadipta has not joined, I think, today. He is busy in the ICU duty. Dr. Vibhuti cleared his IDCCM. He cleared his EDIC even, after with this course. And now he's doing his DRNB also. Quite dedicated, going on completing courses after courses, I think.
Vibhuti, you
So,
didn't
thanks.
tell that you have cleared EDIC 1 also. Huh? That is
Yes,
something really like.
with our
Sir, I
IDCCM
have
course. That's why I asked him, how did you clear EDIC1? Did you prepare anything? He told, I just read your IDCCM, whatever we had prepared, and he gave up the EDIC1 exam in between.
So you
I
have
have
to
only
pay the
went
double
into
fee.
EDIC. Only TRICS IDCCM helped me to clear IDCCM and EDIC 1, sir.
Yeah, so thank you, Dr. Vibhuti, for this
Thank you.
complete and as well as clarifying the doubts of many of the students, I hope. And definitely, as Dr. Vibhuti has told, the exam standard has actually is rising. Every year, the IDCCM is almost touching the standard of EDIC 1. So everybody has to prepare in detail. Previously, people were like not reading about IABP, not reading about CRRT, not reading about advanced neuromonitoring or hemodynamic monitoring. But now the questions are set from the, I would say, EDIC as well as some of the American standard books. So you have to read in detail.
Both theory and practicals. The
Yes.
standards has gone up. I wrote my exam back in 2020, and from then the standards have gone up really high. Every year the bar is being set high. So without further delay, I'll ask Dr. Arun to do some sample questions so that you get an idea how do questions come in the exam. So I'll stop sharing.
Thank you, Dr. Alisa.
Dr. Arun, welcome. And Dr. Arun, you can introduce yourself for our candidates.
Okay, I'm Dr. Arun. I'm working as a senior consultant in JP Hospital, Rourkela, and I have been associated with TRICS IDCCM. So it was a nice journey, and it was really extremely pleasant to know that all of our students are passed. So that is the best thing. And we keep looking at producing similar results in future also. So without wasting further time, we'll start with the questions.
So once he's putting up the question, we'll give a 30 seconds time for you guys to answer in the chat box. It's okay if you're wrong, don't worry. Just put up your options in the chat box. And there are 5 questions, not much, that you just basically get an idea how the questions can come. Okay.
Is the screen visible to everyone?
Yes.
Yes.
Okay. So there is no negative marking. You are all free to answer. Even if you make a random guess, there is still 25% chance that you can still be correct. Okay. So let's start the first question. So which of the following is false regarding management options in vasospasm and DCI associated with subarachnoid hemorrhage? Option A, early treatment with oral nimodipine has shown efficacy in prevention of vasospasm. Option B, delayed cerebral ischemia prevention with hemodynamic augmentation therapy is not recommended. Option C, DCI treatment with hemodynamic augmentation therapy is recommended. Option D, routine use of intravenous magnesium is recommended to treat vasospasm. So which of the following is false? So you can put up your answers in the chat box.
Answer D.
Okay, so should I move to the answer?
Yes, D is the maximum answer everybody has given.
Okay. Yeah. So answer is actually D. Now, the idea of this question, one is subarachnoid hemorrhage is an extremely important topic in the exams. You invariably get 1 or 2 questions from this topic. So this is one of those topics which is extremely important and you must know. Secondly, sometimes the wording is very important. Like you can see in option B and C, there is not much difference. But the key word is option B is talking about DCI prevention. Option C is talking about DCI treatment. So for prevention, hemodynamic augmentation is not recommended. But for established DCI, for treatment, it is recommended. So wording is important. If you change the wording, then options may be right or wrong accordingly. So coming to SH, we have the 2023 guidelines by American Heart Association or Stroke Association. And this is what it says, the recommendations. So DCI prevention with early oral nimodipine. It is the only thing which has a grade 1A recommendation. That is a very strong recommendation for prevention with oral nimodipine. There is less evidence for use of IV nimodipine and use of statins, endothelin receptor antagonists, higher target of hemoglobin 10 versus 7, IV magnesium. DCI prevention with hemodynamic augmentation is not recommended. You don't have to target a higher blood pressure for prevention of DCI. However, for treatment of DCI, hemodynamic augmentation is recommended. That means you can target a higher blood pressure. Anti-seizure medications for up to 7 days for those who present with seizures or patient with high-risk group like MC aneurysm, high grade of subarachnoid hemorrhage, hydrocephalus, cortical infarcts. For those patients, anti-seizure medication up to 7 days is recommended. Anti-seizure medications beyond 7 days for those without any prior epilepsy who present with seizures is not recommended. So this is as per the latest 2023 guidelines. That is why it is important to know the latest guidelines also. Apart from the textbook, it may not be available in the textbook, but it is duly covered in the TRICS IDCCM course. Another important MCQ point of view question, for unsecured aneurysm, use of antifibrinolytics like tranexamic acid is not recommended. And there is some recommendation against the use of tranexamic acid also. So that is another MCQ question. And early aneurysm repair, it should be repaired as soon as possible, preferably within 24 hours. Okay. So this is the background theory which you should know. Now coming to the next question. So this is actually a clinical case scenario questions. Nowadays, we also get many questions of this kind. So I'll just go through it. A 59-year-old type 2 diabetic presented to the ICU post-lab coli. He was admitted to ICU for monitoring post-surgery due to significant comorbidities. Significant OSA with AHI of 42 per hour, triple vessel disease with history of congestive cardiac failure. He is on metformin and empagliflozin for his type 2 DM, which was continued till the day before surgery. He came to ICU on high flow nasal cannula with FiO2 of 0.3, flow of 55 liters per minute, and was visibly in respiratory distress. His lungs sounded clear and ABG showed the following: pH of 7.06, PO2 of 94 on FiO2 of 0.3, PaCO2 of 21, bicarbonate of 14, lactate of 2, sodium was 143, chloride 106, potassium 5.6. His blood sugar level was 98 milligram per deciliter. Which of the following option is best fitting to this diagnosis? Option A, this patient has euglycemic ketoacidosis, which can be precipitated by empagliflozin. Option B, this patient has starvation ketoacidosis as he would have fasted overnight. Option C, this patient has metformin-induced metabolic acidosis. Option D, this patient has lactic acidosis with hyperchloremic metabolic acidosis. So this is a clinical case scenario, and you can write your answers now.
Answer till now. 3 people have answered A. 3 has answered D. Yes, but majority answer is A.
Majority answer is A. Okay.
We'll go ahead with the answer.
Okay. So let us see the case scenario first. It is a known case of type 2 DM, post-surgery, and patient, the crux is the patient is on metformin and SGLT2 inhibitor. So, and it was continued till the day before surgery. Now he is presented with respiratory distress, but lungs are clear. So there is nothing in the chest. Next thing is ABG. ABG is suggestive of pH of 7.06. So it is acidosis, definitely acidosis and metabolic acidosis. Once there is metabolic acidosis, you look for the anion gap. What is the anion gap in this case? Sodium is 143 minus chloride is 106 and bicarb is 14. So anion gap is 23. 143 minus 106 plus 14, 120 is 23. So it is a high anion gap metabolic acidosis. Okay. So now, if it is high anion gap metabolic acidosis, the blood sugar is 98. So possibly this is euglycemic ketoacidosis precipitated by SGLT2 inhibitor. So that is the answer, option A. Getting it? Yeah. Okay. Now let us discuss. So first is the ABG. ABG is one thing, a must-know category. You must all know how to read ABG, how to see ABG, and in clinical case scenarios. First, you look at the pH, whether it is acidosis or alkalosis. Then you look at the PCO2, respiratory acidosis or alkalosis, and bicarb. So in this case, it is primary metabolic acidosis. Once it is metabolic acidosis, you look at the anion gap, whether it is elevated or normal. The causes of high anion gap metabolic acidosis, normal anion gap metabolic acidosis, all these things you must know. Now, compensation formulae also, I'm not going to discuss in detail, but yes, there is compensation formulae. And once there is high anion gap metabolic acidosis, you also look at the gap calculation, that is delta anion gap and delta bicarb gap. And depending on the ratio, there may be pure high anion gap metabolic acidosis or maybe associated mixed disorder. So coming back to our patient, in this case, we pH was 7.06, bicarb was 14, and it was metabolic acidosis with anion gap of 23, high anion gap metabolic acidosis, but delta gap is 1.1. So 1.1 comes out to be a pure high anion gap metabolic acidosis. So what are the causes of pure and high anion gap metabolic acidosis? It could be like this. These are the causes, mud piles. So in this case, possibility is more of euglycemic ketoacidosis. Okay. Another thing is lactate. Lactic acidosis can also cause a high anion gap metabolic acidosis, but in the question, lactate was normal. In our case scenario, if you go back, lactate was normal. Lactate was 2. So that is why lactic acidosis is not the right answer here. But had the question been little bit twisted, in the question, if they had said that lactate was high, say lactate was 6 or 8, then the best answer might have been metformin-induced metabolic acidosis, because metformin will cause lactic acidosis. Okay, so this is the thing. And coming back to the drug, the SGLT2 inhibitor, small things, some things we should know. Around 3% of decay admissions, because of SGLT2 inhibitors, they cause euglycemic ketoacidosis. And why? What's the difference between euglycemic decay and decay? So main difference is the blood glucose level. Level is less than 250 in euglycemic decay, and it is obviously more than 250 in case of decay. The symptoms obviously will be more exaggerated in decay compared to euglycemic decay. So what is the basic pathophysiology? If you look how the SGLT2 inhibitors act, so they primarily act on the kidney and the pancreas. So in the pancreas, they reduce the insulin secretion and increase the glucagon secretion. So the insulin-glucagon ratio is reduced. Less of insulin, more of glucagon will lead to increased lipolysis, free fatty acid, and finally ketogenesis, more ketone body formation. This is one. Second, they act on the kidneys to cause glycosuria. That is why the serum glucose will not be elevated, because it is eliminated in the urine. And they also cause natriuric acid and ketone body reabsorption. This is important, because not only they increase the ketone body formation, those ketone bodies, when they are eliminated in the urine, they also cause increased reabsorption of the ketone bodies. That is why they further increase the plasma ketone bodies with euglycemia. That is why it is euglycemic ketoacidosis. The recent the guidelines of anesthesia society, they recommend that this SGLT2 inhibitor, they should be stopped at least 3 days before surgery. But if you see this case in our patient, the drug was continued till 1 day before surgery. You can see it was continued till 1 day before surgery. That is another drug. Ideally, because this drug has a half-life of around 12 hours. So it requires 5 to 6 half-life for complete elimination of the drug from the body. So ideally, this should have been stopped before 3 days. And that is also another crux. If you know this background of the drug, then also you can suspect that yes, perhaps this patient has gone into euglycemic ketoacidosis because of the SGLT2 inhibitor. Okay. So coming to the next question, another lengthy question. So 69-year-old presented to ICU after brought by ambulance. He was drowsy and difficult to rouse. He was lying on the floor at least for last 18 hours before being found by his neighbor who called the ambulance. His blood investigation showed the following. He has a background history of diabetic nephropathy with CKD stage 3. He was well in the community and has never been on hemodialysis earlier. His current vitals are heart rate of 140 per minute, sinus tachycardia, blood pressure of 88 by 74 millimeter mercury, saturation of 88% on high flow FiO2 of 0.7. His periphery was cold and capillary refill was more than 8 seconds. His JBP was raised, arterial line trace was this, and point of care ultrasound, the POCUS echo found, this was the finding on the echo. After initial resuscitation, what will be next action? Option A, urgent pericardiocentesis for uremic pericarditis. Option B, urgent hemodialysis for AKI. Option C, urgent CRRT and pericardiocentesis. Option D, urgent intubation and ventilation for hypoxia. And the blood investigation reports are hemoglobin of 6.4, TLC 18,000, platelet of 54,000, creatinine of 4.6, urea 120, sodium 154, and potassium 6.4. So you can write your answers now.
A, and then 2 people have answered C. A and C is the majority, I think. A and C.
A and C, okay. To be honest, both options are actually correct. We'll discuss how. So what is the diagnosis? What is this POCUS is suggestive of? This is the heart, and there is some fluid around the heart. There is so much fluid, it is actually compressing the heart. So what is our diagnosis? So this is pericardial effusion, possibly leading to cardiac tamponade, right? And based on the history, as we can see, patient is a known case of CKD, and the parameters that we see, urea, creatinine already raised, potassium high. So most likely it is uremic pericarditis. So patient, yes, option A, urgent pericardiocentesis for uremic pericarditis. Yes, it is correct. Okay. But what option C says? It says that it is pericardiocentesis along with CRRT, continuous renal replacement therapy. Even if we do a pericardiocentesis for this patient, patient will die of hyperkalemia or renal failure. So you have to take care of both things, cardiac tamponade as well as the kidney component, because urine output is also low, blood pressure is very low, potassium is already 6.4. So option A is correct, but not the entire treatment that the patient requires. So correct answer is option C, because you also have to go for CRRT along with the pericardiocentesis. You have to do both to save the patient. Okay. That is why it has to be the most appropriate answer. So correct answer is pericardiocentesis along with CRRT. So we'll just discuss a few points. So echocardiographic signs, separation of pericardial sac based on the effusion size. They have been classified as trivial, small, moderate, large. And the size of the effusion doesn't necessarily predict the pericardial tamponade. What is more important is the rate of rise. The rapid is the rate, more dangerous it can be. Okay, so we'll not discuss in detail, but there are certain things. Yes, diastolic right ventricular collapse is an important sign. Systolic right atrial collapse, another important sign. And plethoric IVC with minimal respiratory variation. And exaggerated respiratory cycle changes in mitral and trispiratory inflow velocities as a surrogate for pulsus paradoxa. If you looked at the arterial line, there is already, just look at the arterial lining trace. Yeah, it is also suggestive of pulsus paradoxus, the arterial line trace. And if you look, diastolic is 74, systolic is 88. So there is hardly any pulse pressure. Pulse pressure is hardly 14 in this case. So low pulse pressure case. So that was again suggestive. And these are the theory part. So coming to the treatment, obviously we have to ABC approach and immediate chest reopening in perioperative period if it occurs after a major open heart surgery or pericardiocentesis if patient is relatively stable. So that is the treatment. Now coming to the next question, which of the following is false about prone positioning in the management of ARDS? So again, this is a basic physiology question about prone position, and it is a simple question actually. So option A, which is false, we have to answer. Option A, it improves VQ mismatch because pleural pressure is less likely to exceed airway opening pressure and cause airway closure. Option B, it leads to more homogeneous ventilation because of reduction in the difference between dorsal and ventral pleural pressure and more uniformity in compliance of the lungs. Option C, it increases the FRC by 300 to 400 ml. Option D, drainage of secretion becomes difficult due to poor access to patient's airway. So which is false? You can answer now.
D. Okay, so choose the answer D.
Okay.
D
So
is the
everyone is
answer.
saying D. So
Yeah.
we'll go with majority because this is a democratic country and election is going on. So we'll go with majority. So answer is D. Yes, drainage of secretions actually becomes easier, not difficult. Okay. So just the basic things, the difference between supine and prone position. What are the advantages of prone position? Improve VQ mismatch. Yes. More homogeneous ventilation, less lung deformation, increased FRC, improved drainage of secretion. That was the option. There is improved drainage of secretion, improved response to recruitment maneuvers, and improved mechanics of chest wall in obesity. So all the advantages are there in prone position. Now this is just a diagram to explain simple things. So if you look in the supine position, the upper zone, the airway is actually alveoli are actually over distended, hyperventilated, over distended. There is hyperinflation, more ventilation but less perfusion. In the lower zones, there is more perfusion but less ventilation. So there is collapse of the alveoli. So VQ mismatch is more in supine, but you can see this is more distended, this is less distended. But in prone position, almost all the alveoli are almost equivalently distended. So the VQ mismatch is less in prone position. Plus, there are various other mechanisms like the weight of the heart and mediastinum. It is not putting pressure on the lungs in the prone position. So that is why it is more advantageous. And the compliance is also better in prone position. Now coming to the last question. Regarding ICP monitoring in traumatic brain injury, which statement is false? Option A, ICP monitoring is indicated in patients with a severe traumatic brain injury, GCS 3 to 8 after resuscitation, and an abnormal CT scan. Option B, ICP monitoring is indicated in patients with severe TBI with a normal CT scan and two or more of the following: age over 40 years, unilateral or bilateral motor questioning, or systolic blood pressure of less than 90. Option C, multiple trials showed mortality benefit with ICP guided therapy, ICP less than 20, compared to therapy based on conventional imaging and clinical examination. Option D, rescue ICP trials showed decompressive craniectomy in patients with traumatic brain injury and refractory intracranial hypertension resulted in lower mortality and higher rates of vegetative state. So which one is false? Okay, so C, most of them are answering C. So we'll discuss the answer now. Now option A and option B are directly taken from the Brain Trauma Foundation guidelines. So it is as per the BTF guideline, the latest guidelines of indication for ICP monitoring. Option C, you see, ICP monitoring is not a therapeutic modality. You're just monitoring ICP. It is not a therapeutic modality to improve your mortality, to show mortality benefit. So correct answer is option C. By monitoring ICP, you are not going to have mortality benefit. Okay. And option D is about a trial. Sometimes landmark trials also you should know. So we'll discuss the rescue ICP trial. In that trial, they actually found that patient had lesser mortality. Less patients died, However, the quality of life was not very good. So more vegetative state patients were found. So indication of ICP monitoring, this is as per the Brain Trauma Foundation guidelines. The first two options we have already discussed. It should be done in patient with GCS of 3 to 8 and abnormal CT scan, or if CT scan is normal, if at least two of the following is present: age over 40, unilateral or bilateral motor posturing, or systolic blood pressure of less than 90. Now coming to, there are two important trials, the DECRA trial and the rescue ICP trial. So the question in our question, it was the rescue ICP trial. I'll not go into the details of the trial, but the only thing is they have tried to manage conservatively versus they have done decompressive craniectomy and looked at the outcome. So what they found in the surgical group, mortality was less, but even if less patients died, the survival was not associated with a good quality of life. There was increased rates of vegetative state, 8.5% versus 2.1%. So even if less patients died, the quality of life was not very good. This is as per the rescue ICP trial. And there was another trial, decompressive craniectomy, DECRA trial, that also found that there is decreased burden of intracranial hypertension. Obviously, if you do a massive frontotemporoparietal decompressive craniectomy, obviously your ICP is going to be less, but the quality of life may not be very promising. And the DECRA trial found that there was decrease in ICU stay, but worse outcome for extended Glasgow Coma Outcome Scale at 6 months. There are some trials which earlier they were not asking, but I think now they are asking in the MCQ options also. So the landmark trials that we have to know, because they may be asked in one of the options in the MCQ. Okay, so I think that concludes our question answer session. So over to you, Dr. Alisa.
Thank you, Dr. Arun, for those 5 sample questions. And I think the students would have benefited from those questions. Any questions from the students? Any questions you would like to ask? Please post it in the chat group so that we can answer the questions. If no questions, once you have enrolled for the course, you will be added to a WhatsApp group where you can post all your questions. And from there on, you can go through the modules, and after each module, there'll be a mock exam, after which you can ask us any questions and we'll be answering you in the chat group. Any other questions from the attendees? How many hours of... Okay, there's a question in the chat box. How many hours of day dedicated to clear the exam? It is very difficult to answer, but it depends on each student. But I would say dedicated 2 hours of study every day will surely help you clear the exam.
Exactly. The dedication word is a relative term. So if you are doing hard work in current scenarios, it is not of much use. Rather, I would always advise all our candidates in different courses, whether it is TRICS IDCCM, TRICS 1, that is for EDIC 1, as well as EDIC 2, as well as our top course for DRNB. It is smart work which matters. So, and our dedicated course, our faculties all believe in the smart work, and they would be definitely helping you to do maximum of your efforts in less hours, because we all know you are all working, and in your family time as well as in your like the personal time, if you are dedicating it in a very wise way, and definitely you will get the success. Yeah. So anyone who wants to share any of your queries from the attendees, we will be happy to answer.
There's one more question. Is working in ICU is some mandatory to clear understanding concepts? This is again a little tricky question to answer. If you're working in an ICU, what you study, it will be easier for you to practice, so that what you're going to study for this theory and practicals is basically to improve your knowledge, to practice and to improve further in your career. So I would suggest working in an ICU during your study time too. Any other questions from the students?
So if there are no more questions, Dr. Alisa, Dr. Sanant, if you are here, you can also share some of your tips and tricks to the candidates. And if anyone wants to post any of the questions from the attendees. So we are waiting for your feedback in the dedicated WhatsApp group that we have created for the free webinar. So if you have any queries, our team would be helping you to clarify the doubts. And believe us, you are going to rock the exam. And all the best for your upcoming theory exam as well as your practical exam and all your future clinical practice, and we will be helping you. So, okay. So there are certain questions I think we can help you out in if you are posting in Dr. Alisa or like Dr. Arun or Dr. Sasi. So these are something which are very relative questions like working as a physician and then less time spent in ICU. So there are clues, there are certain strategies that to help you out in your exam preparation. Don't worry. Practical
What
exam.
about the? Yeah.
Yeah,
Yes,
yeah,
Alias.
Dr. Sasi, please take this question.
Yeah. What about practical exam preparation? Once you clear your theory exam, we'll be giving you a same module for how to prepare for the practical exam. We will tell you how to prepare separately for the Viva and how you'll prepare separately for your case. So that will again be detailedly discussed like this, how you prepare for your theory exam. Surely we will guide you, handhold you through your practical exam preparation too.
The preparatory course is ready for the practical also, but before that you have to first clear your theory and then we'll have our practical course. Dr. Arun is ready to help you out how to go to the have a front foot and just score 4 and 6.
No, the candidate is very confident that after theory he'll be appearing for the
Yes,
practical. That's good.
exactly,
That's good.
exactly. Okay.
Any other questions?
Thank you. Much appreciated all your presence. Dr. Sasi, Dr. Alisa, Dr. Sanant, Dr. Arun, Dr. Vibhuti, and all our dedicated faculties who could not join also today, but there are other core faculties who are devoting their time to prepare the exam preparatory materials and modules. And all the attendees, despite your busy schedule, in the short notice, you all have attended and posted such beautiful, I would say, thought-provoking questions, how to clear it with less amount of efforts. So that is a very, I would say, smart question somebody has posted. So we are there to help you, and definitely we would be coming up with certain strategies that would definitely make you confident to appear with less fear as well as less confusion in your exams. Thank you very much. All the best. Yeah.
Thank you. Thank you, everyone. All
Thank
the
you,
best for
everyone.
your exams.